Yeah, I would say the physician envelope is somewhat of a disconnect, that we've created and negotiated fee schedules that have seen us very focused on a model of intervention as opposed to a continuum of care. And that makes sense in some cases. So in some of the surgical disciplines,
Right.
when you have a shortage of providers and you have a lot of demand, you may want to incent more performance or more volume. But in many of the areas, particularly for the frail elderly, that may not make sense. So why would we set up a system that says unless you do a lot to people in an interventionist way, you won't make a good living? And we're beginning to look more and increasingly at why do we need to be tied to a fee schedule per se? How might we look and say we're interested in the unique skill set of physicians being deployed to the right place, right time? We're also looking at how do you expand appropriately the scope of practice of, frankly, less expensive providers and ensure that that continuum can be met and that the work that needs to be done gets done without economically penalizing the provider. So in my view, with the shortage of providers that we have, I think we can stand back or could stand back and say, we're going to guarantee your income. So don't worry about that. We're not going to chase the billing machine anymore. We are probably going to change your work and ask you to do work that is higher value and that only you can do. And I believe that really is part of the longer term discussion that Ontario has to engage in.
Right. So part of the solution is not to incent certain procedures and behavior, that people may do because it's there.
Well, I think the incentive piece is a really complex piece. It appears to me in Ontario we've added incentives without going back and talking about the base funding. So we've almost got a malalignment with incentives of not really saying, well, what do you have to deliver for your base income? And then what exactly are we incenting? And I think incentives have worked remarkably well where we've identified a pent-up demand, so like in wait times, hips and knees, cataracts, MRI, the list goes on, and there was identified pent-up demand. Mm-hmm. So I think that's worked exceptionally well. Right. I think where we have to revisit it is if you're talking about a complex, frail, elderly person, and that's the population associated with ALC and long lengths of stay in hospitals, and then moving into long-term care, perhaps more than we'd like them to be. We'd like to see more of them go home with home supports. That's where I think we have to re-examine the compensation models. And I think what I've learned is there's no right way to pay clinical leaders or perfect way to incent hospitals and care organizations. Right. I think we're going to have to go back and have a very targeted discussion about have we aligned the behaviors, the structures, the outcomes, and the processes to get where we want to go. And where there are direct disincentives, and we see this frequently, the fee schedule says if I see the patient and then you see the patient, we both can't bill for a consult. Does that really make sense if what's best for the patient is seeing both of us for some good, legitimate clinical reason? Why wouldn't we rather say both of us will be fairly compensated, but we won't ask you to do or not do necessary or unnecessary work. We'll ensure that incentives are aligned with the work we need done.